Before moving forward to antiviral drugs, let's first see how a virus infects a typical host cell. Now, this is only a general idea, and there is much detail involved depending upon the type of virus infecting the cell, the receptors it binds to, either it replicates in the cytoplasm or the nucleus, or if it carries its own enzymes for replication or uses the host's reverse transcriptase enzymes. But this is just as simple as it could get to understand the mechanism of action of the drugs that are used in antiviral therapy. Now here we have the red virus and the blue host cell. It can be any cell, for example CD4 cells in HIV. Now what the virus does is attaches to specific receptors on the surface of the host cell. Now whenever this idea of host cell attaching to the virus via a receptor came up, I used to get very confused because it almost seemed like we have a receptor to welcome the virus inside. That just doesn't seem right, does it? Turns out, thankfully, that's not the case. These receptors are actually playing physiological roles in our body, and the virus actually tricks them into thinking that they are the substances that they naturally bind to. For example, HIV virus will trick the CD4 receptor, which normally binds to MHC class II, and activates Th helper cells. But in the presence of HIV virus particle, it will be tricked into thinking that the HIV glycoproteins are the substrate that it naturally binds to. After binding to this receptor, there will be the phase of adsorption where either a bacteriophage will inject its DNA or RNA, or there will be complete endocytosis of the viral particle. This phase is called penetration. After that, the endocytosed vesicle will undergo uncoating, and thus the nuclear material will be released. Firstly, there is early protein synthesis, and then there is the nucleic acid synthesis, which is the actual aim of the virus. And then after the nucleic acid synthesis, there will be protein synthesis, and new viral particles will be packaged and processed and thus released to infect more cells. The purpose of making this diagram was to put the drugs where they act on this diagram. So first, we'll see the drugs which will inhibit the adsorption phase, or that will inhibit the interaction between the viral glycoprotein and the receptor. They will be the entry or fusion inhibitors. The drugs included are enfuvirtide and maraviroc. Next, we can inhibit the uncoating phase by inhibiting the proton pump in the endocytosed vesicle that is actually needed to acidify the vesicle and then release the nuclear material. And the drugs that are used in this phase are amantadine and rimantadine. Next are the nucleic acid synthesis inhibitors, which can be divided into the nucleoside reverse transcriptase inhibitors, the non-nucleotide reverse transcriptase inhibitors, and two other drugs, which are acyclovir and foscarnet. The late protein synthesis and processing of the protein can be inhibited by protease inhibitors. And lastly, the packaging and assembly leading to the viral release will be blocked by neuraminidase inhibitors such as oseltamivir and zanamivir. First, we'll see the drugs that are used against herpes virus. They can be divided into those which are antimetabolites, that means they are prodrugs and they will require metabolic activation by the host cell or viral enzymes, while the next ones will be non-antimetabolites, which will be active as such and do not need activation. The antimetabolites will include the drugs acyclovir, ganciclovir, and idoxuridine, while the one non-antimetabolite we'll discuss is foscarnet. Now, as I said, these antimetabolites are prodrugs. Acyclovir is actually a purine nucleoside analog and needs to be converted into its active form, that is the triphosphate form, by 3 phosphorylations. The first phosphorylation is done by the thymidylate kinase enzyme of the virus. That is, it needs the virus enzyme to get converted into its active form. while the second and third phosphorylation is done by the host cell kinases. After it has been activated into its triphosphate form, what it does is, one, it acts as a substrate for viral DNA polymerase because it resembles the nucleotides that are normally interacting with the DNA polymerase. And secondly, as it does not have the 3' end hydroxyl group, that's why it cannot bind another nucleotide and thus continue the chain formation. That's why it will also cause chain termination. As we saw that acyclovir needs the first phosphorylation by the thymidylate kinase of the virus, that's why it will be only active against those viruses which have this enzyme, that is HSV, herpes simplex virus, and varicella zoster virus VZV. Acyclovir is the drug of choice for encephalitis that is caused by HSV, also in genital herpes where it reduces the frequency and severity of the herpetic lesions. It is also useful in herpes zoster, mucocutaneous HSV, and herpetic whitlow, that is a nail bed infection. An important point for the mode of resistance is that those viruses which do not have the TK enzyme are naturally resistant to it, and those which do have it can become resistant by not having it or changing it. On oral administration, acyclovir does not have that many side effects, but on IV administration, it can cause a prominent crystalluria and neurotoxicity. But one thing that is good about acyclovir is that it is not hematotoxic. Now, the reason for that is because it needs the first phosphorylation from a viral enzyme, right? So it cannot get converted into its active form in normal bone marrow cells, say. That's why it is not hematotoxic. Coming to ganciclovir, it may not need the TK enzyme. Now it can use it, but it might not need it. That's why it is also like acyclovir effective in HSV and VZV infections, but it can also use the phosphotransferase, that is UL97 enzyme of the CMV virus, and that's why it is also effective against CMV virus. It can also be phosphorylated by cellular kinases of the host cell, and thus their side effects will be anti-cancer drug-like side effects. That is, it will cause bone marrow suppression and mucositis. It can be used in CMV retinitis, CMV infections in immunocompromised patients, and as I said previously, HSV and VZV infections as well. Other side effects can include mucositis, crystalluria, just like acyclovir, fever, and rash. Idoxuridine is a thymidine analog, and as we know that thymine is only present in the DNA, that's why it will only act against the DNA viruses by converting into the triphosphate form and thus inhibiting viral DNA synthesis and thus replication. It can be used in keratoconjunctivitis of HSV. Let's say you have an HIV patient and you don't want to use ganciclovir because it suppresses this bone marrow, and HIV patients are associated with infections. That's why you need that bone marrow to work. So in that case, you cannot use ganciclovir, but then you can use foscarnet, which is a direct DNA and RNA polymerase inhibitor. Foscarnet can also be used in resistant cases where the virus is resistant to acyclovir because either it has deleted the TK enzyme or has mutated it. So foscarnet can be used because it does not need any activation by the TK enzyme. Side effects include dose-dependent nephrotoxicity, and it is very, very severe, causing acute tubular necrosis, electrolyte imbalance with hypocalcemia, leading to tremors and seizures, and also hyperkalemia and acidosis. One last thing about foscarnet is that, as I said, it is mainly used in HIV patients, and we know that HIV patients are suffering from many other infections as well, such as pneumocystis jirovecii infection, and for that the patient might be taking pentamidine. Now, pentamidine is also a severely nephrotoxic drug, and if combined with the foscarnet, it can lead to additive nephrotoxicity. Coming to the drugs used against HIV virus, first you need to know that HIV is a retrovirus. And a retrovirus means that it has RNA as its genetic material, but also has the enzyme RNA dependent DNA polymerase. Now, this enzyme will convert the viral RNA into a DNA copy, and thus this DNA copy will be inserted into the host cell genome. The objective of anti-HIV therapy is to suppress HIV replication and improve the immune status of the person, and to prevent emergence of drug-resistant virus, and lastly, to prevent the opportunistic infections that are associated with HIV-infected patient. To achieve all of these goals, antiretroviral therapy or highly active antiretroviral therapy, also known as HAART, is used nowadays. And the principle behind this is that the use of multiple drugs that will act on different viral targets by a different mechanism of action will have synergistic effect and decrease the occurrence of resistance. Coming to the drugs that are used against HIV virus, they are fusion inhibitors, reverse transcriptase inhibitors, also known as RNA-dependent DNA polymerase, protease inhibitors, and integrase inhibitors. As we discussed in the beginning, in order for a virus to enter the host cell, the glycoproteins on the surface of the virus need to interact with the cell surface receptors of the host cell. And in the case of HIV, this host cell is a CD4 positive cell that can be a T helper cell or any antigen presenting cell actually. The virus will have two receptors, GP41 and GP120, while the CD4 cell will have CD4 receptor and a chemokine receptor known as CCR5. Now the GP41 will interact with CD4 and the GP120 will interact with CCR5, and thus the virus will enter the cell. But fusion inhibitors are of two types. One will block the GP41 and thus CD4 will not be able to interact and bind to it. And the next will block the binding of GP120 protein to the CCR5 and thus not let the virus to enter the macrophage or the CD4 positive helper cell. The fusion inhibitor binding to GP41 is enfuvirtide, and the one blocking the binding of GP120 is maraviroc. Enfuvirtide is given as an IV injection, and there can be pain and erythema at the site of injection. It is basically used as an add-on drug in the patients who are not responding to the ongoing antiretroviral therapy. There is no cross-tolerance with other anti-HIV drugs. While maraviroc, as I said, is CCR5 antagonist, it can be given orally, and its side effects include cough, myalgia, arthralgia, and diarrhea and hepatotoxicity. Coming to the reverse transcriptase inhibitors, which will not let the virus to convert its RNA into DNA and thus incorporate into the human genome, can be divided into those that are nucleoside analogs and those that are non-nucleosides in nature. Nucleosides analogs are known as NRTIs, that is nucleoside reverse transcriptase inhibitors, and the non-nucleosides are known as non-nucleosides reverse transcriptase inhibitors. Can act on both HIV-1 and HIV-2 types of HIV, while non-nucleosides can act only on HIV-1 and not on HIV-2. Now we'll see the NRTIs in detail. As we said that they are nucleosides in nature, that means they are prodrugs, and they need to be converted into triphosphates by cellular kinases, and thus can have the potential of, or do have the potential of, bone marrow suppression. Because these kinases are present in every cell, and the rapidly dividing cell of the, for example, myeloid cells of the bone marrow will be affected by these drugs. After the active triphosphate form has been formed, it will do two things. Firstly, as it is a nucleotide, it will compete with other natural nucleotides in the DNA formation. And secondly, it will cause chain termination because it does not have the terminal 3' hydroxyl group that needs to be there in order for another nucleotide to get attached to it and continue the chain formation. So it will stop the DNA formation by the reverse transcriptase enzyme. The first NRTI to discuss is zidovudine. It is also known as azidothiamidine, and from this name we can see that it is a thiamidine analog, and the mechanism of action has already been discussed. What it does is basically it protects the uninfected cells that have not yet been infected with HIV and their DNA has not yet been incorporated with HIV DNA. It is given orally and chiefly metabolized in the liver by glucuronide conjugation. So another drug that comes to mind by this sort of conjugation is acetaminophen. So acetaminophen will compete and increase the toxicity of zidovudine. Azoles, as we remember, are enzyme inhibitors, right? So they will also increase toxicity of zidovudine. This drug can be used both in combination with other drugs and also for prophylactic purposes. Other NRTIs only differ in their side effects. They can be lamivudine, amtricitabine, and among these, lamivudine stands for least toxic and least potent, L for least toxic and least potent, while amtricitabine is the least toxic. Other side effects are peripheral neuropathy, which are more pronounced with zalcitabine, stavudine, and didanosine, while pancreatitis is more pronounced with zidovudine, didanosine, and zalcitabine. Now, if we are using combination therapy, we should remember to not combine similar nucleotide analogs. For example, stavudine is also a thiamidine analog and zidovudine is also a thiamidine analog. So if we combine both of these, what will happen is that they will want to bind to the same spot and thus compete with each other. And that's not what we want. We want them to work in synergy. Coming to the NNRTIs, they are non-nucleosides. That means they will not act by the same mechanism, but by acting directly on the reverse transcriptase enzyme and inhibiting it. It will need no activation, unlike NRTIs, and thus will cause no bone marrow suppression, and they do not have any cross-resistance with other anti-HIV drugs such as NRTIs, and their action is additive or synergistic with NRTIs. There are two main drugs that we'll discuss. One is nevirapine and second is efavirenz. Nevirapine is a lipid-soluble drug and it has good GIT absorption on oral administration. It crosses the placenta. That is why one dose is given at the delivery time to inhibit the vertical transmission, that is from the mother to the baby, of HIV infection. Another thing to remember about nevirapine is that it is an inducer of the enzyme 3A4, that is a major and most common enzyme of P450. It also causes rash and increased liver function tests. Efavirenz has a longer half-life and its side effects are a bit odd, that is dysphoric dreams, that means nightmares simply. Coming to the protease inhibitors. Now, just like our body cells produce propeptides, which are then, a part of them are cleaved off and then converted into an active form, same is the case with viruses. The enzyme aspartate protease is a viral enzyme that is encoded by the pol gene and that cleaves off precursor polypeptides in HIV buds to form the proteins of the mature virus core. What the protease inhibitors will do is competitively inhibit the HIV protease enzymes and prevent the cleavage of viral polyproteins to final functional, structural, and enzymatic components of HIV, and thus immature and non-infectious viral particles will be produced. This dipeptide enzyme, protease or aspartate protease, is not present in mammalian cells, but we are not very sure about this. Now, a mode of resistance, as you might imagine, is to change this aspartate protease. Good thing is that there is not complete cross resistance among the protease inhibitors, and among the protease inhibitors and the RTIs, there is no cross resistance. The important drugs are ritonavir, indinavir, nalfinavir, and atazanavir. Regarding ritonavir, it is a major enzyme inhibitor, P450 enzyme inhibitor, and will have drug interactions. It is mainly combined with other protease inhibitors because it will increase their half-life and bioavailability by inhibiting their metabolism. Indinavir has a side effect that is nephrolithiasis due to crystalluria, and this can be managed by good hydration of the patient, and there is also hyperbilirubinemia. Nalfinavir has only diarrhea as its side effect. An important thing about protease inhibitors is they cause a syndrome of disordered lipid and carbohydrate metabolism, leading to central adiposity and insulin resistance. Now, this is a serious side effect which is very less seen in azitanavir. Now, let's say the reverse transcriptase has succeeded in making DNA from the RNA of HIV. Now, we have other drugs that are integrase inhibitors that won't let the viral DNA get integrated into the human genome. The main drug is raltegravir, which is effective in both HIV-1 and HIV-2 types of HIV, and the main side effects are headache, nausea, and fatigue. Now we'll see the anti-influenza drugs. They can be divided into those that end with mantidine and the others which end in amivir. Amantadine and rimantadine are the first two drugs, and oseltamivir and zanamivir is the other class. Amantadine, by binding to a proton pump in the endocytosed vesicle in which the virus particle is present, which it will inhibit this pump, which is needed for acidification of the virus core, and thus will prevent uncoating and assembly of influenza A virus and not B. It prevents viral replication and can be used both in prophylaxis and treatment of influenza A virus. It also has an anti-Parkinsonian effect, if you remember from the anti-Parkinsonian drugs video, and there is minimal cross-resistance with oseltamivir and zanamivir. It is contraindicated in pregnancy because it has teratogenic effect. The side effects include ivado reticularis, GI distress, dizziness, ataxia, slurred speech, and resistance to this drug is very common. Rimantadine is the same as amantadine, but with a longer half-life. Oseltamivir is going to act on the step of the release of the viral particles and thus will inhibit further cells to be infected by the virus. It selectively inhibits influenza A and B virus neuraminidase enzymes. And these are enzymes that prevent clumping of the virions so that more particles are available to infect host cells. And it can be used in both A and B influenza. Side effects are simply GI side effects and flu-like symptoms like nose, throat irritation, fever, tiredness, etc. Zanamivir is same as oseltamivir, and its oral bioavailability is low, so it is given via inhalation but is contraindicated in people with airway disease. It can cause bronchospasm, headache, and dizziness as side effects. Lastly, we'll briefly look at the drugs that are used as anti-HPV and anti-HCV drugs. The anti-HPV drugs are mainly suppressive in their function, while anti-HCV are eradicative. They include the drugs interferon alpha, sofosbuvir, cimeprevir, and ribavirin. Interferons are proteins that are produced by virus-infected cells and can also be produced by recombinant DNA technology. Now, interferon alpha will activate the host cell RNase enzyme to degrade the viral RNA, and they will also increase the natural killer cell formation to destroy the cells that have been infected. They are contraindicated in pregnancy, and some side effects include flu-like syndrome and severe depression. The next, sofosbuvir, is a nucleotide analog and thus will inhibit RNA polymerase, as we've previously discussed for other analogs. Cimeprevir is a hepatitis C protease inhibitor, while ribavirin only acts on RNA synthesis because it is made up of riba. Riba stands for ribose, and we know that ribose sugar is present in RNA molecule. So it only acts on RNA synthesis inhibition by inhibiting RNA polymerase. It is a synthetic purine nucleoside analog. We have discussed that. And it can also be used in parainfluenza, measles, adenovirus, RSV virus, and hepatitis C virus. Its mode of administration is mainly an aerosol, which can cause conjunctivitis and respiratory irritation. It is contraindicated in pregnancy as well because it is teratogenic. And other side effects can include tiredness, cough, and dyspnea. That's all about antiviral drugs.